Okay, continuing on with documentation. We talked about the problem-oriented medical records, but another type of reporting is source-oriented medical records. In source-oriented medical records, each discipline makes their own notes in a separate area of the chart. So the physicians are all going to chart under progress notes. Nurses will chart under nurses' notes. So it's kind of like everything is scattered throughout the chart, and it's very fragmented, but each area has their own section. So if you want to look at, a note from the doctor, you just go to the progress notes, and that's where you'll find that. I mentioned to you guys that this doesn't make quite as much sense as the problem-oriented medical records, but this is the more traditional format. This is the way you are going to find most of the notes, so you will have to kind of search through the chart to find information about the same problem if it is documented by several different disciplines. Source-oriented medical records also use narrative notes. Narrative notes are the type of notes you're going to learn how to write in assessment, where you are literally documenting every aspect of that assessment in a handwritten form. It is a bit more time-consuming, but again, you do get a ton of information in that assessment, which is very good. Now, computer records. With computers, anytime we have computers, we have the possibility for legal issues. We all know that we worry about hacking and we worry about access to certain things. So passwords, usernames and logins and passwords are used to limit access to certain areas. So for instance, the housekeeper is not necessarily going to have full access to an entire patient's record. They're going to have access to the part where they can know what kind of things they've got going on infection control wise, so they know how to clean the room or something like that. You also need to monitor the monitor. When you are looking at a patient's chart and it's popped up on the monitor, watch the other family members in the room. Are they trying to have a look at that monitor? Your job is to protect the patient's privacy, so if that means you have to turn the monitor so only you can see it, or in some way you've got to go the extra mile to protect that patient's privacy. Make sure every time you're on the computer, don't get up, go somewhere, check on something, and come back without signing off the computer. Never remain signed on. That gives someone else the opportunity, using your permissions, to click around in someone else's chart. But it's going to look like you did, and you're going to be the one who's answerable for that. So obviously, the business office, the lab, doctor's office, pharmacy, everybody needs access to a patient's chart, but we don't all need the same access. The one benefit for nurses is, we do have a lot of access. We have access to almost everything in the patient's chart, but there again, you shouldn't be clicking into patients' charts that you have no business looking into. Most hospitals who use computer charting do have bedside computers, so it is easier, you're not having to wait and run out into the, nurse's desk area to sit down and write your assessment. You could pull that assessment up, and as you are performing your assessment, you could document as you go, which is obviously optimal. So our issues obviously are confidentiality. We talked about that. Clearly, we are always worried about hacking, so there's always going to be security updates and security protocols that you have to follow. And then you always have to go back to what happens when the computer goes down, because, computers never go down. I mean, of course they go down. So even though we have these wonderful computers and they do a lot of great things for us, the bottom line is you still have to know how to chart by hand. So narrative charting is a form of charting that is more of a handwritten out version. It's not a checklist. It's not, a flow sheet. This is you starting at the beginning saying alert and oriented to person, time, and place, vital signs stable, afebrile, blah, 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 blah. You're going to learn that assessment. You're going to be given a little cheat sheet that helps you get through that assessment. We also chart all of our information chronologically. So what you do at 7 a.m., you chart at 7 a.m. What you do at 9:30 a.m., you don't chart at 10:30 and just write it down for 10:30. If it's 10:30 and you did it at 9:30, you make a late entry for 9:30 a.m. Usually, narrative charting is used with source-oriented records, whereas SOAP notes were used with problem-oriented medical records. One of the main advantages of narrative charting is it is very thorough. You leave no stone unturned. You will check everything and you will chart everything. This is why you start here. You are going to learn how to do the Cadillac of assessments and how to chart that assessment. Then later, when you can drill that down into a flow sheet, you'll still know all the information and you'll actually appreciate that flow sheet a little bit more. The disadvantage is it's difficult to find all the data about a specific problem because we are literally charting everything. So it's not just the abnormals, we are charting all of the normals. So these things tend to be fairly long. It's nothing for a full head-to-toe assessment to be a half a page or even 2/3 of a page long. So they're also time-consuming to sit down and write. So you can imagine they've looked for other options to try to make those notes a little smaller. All right, so the SOAP notes that I talked about with the problem-oriented medical records. SOAP stands for Subjective, Objective, Assessment, and Plan. The subjective data is what we basically report that the client is telling us. So the patient is saying, they have a pain in their left lower quadrant. And say it in quotes whenever possible. Say it the way the patient expresses it. Then your objective data is all of the data that you can objectively use your senses and record. So what you see, what you hear, what you feel, what you smell, okay? The assessment is your statement of the problem. So this is when you take all that subjective and objective data, you kind of mash it all together and come up with an idea that this is that patient's issue. And then your plan is your plan of action, how you plan to go about making this issue better or resolving it if possible. So because SOAP isn't enough, we have to have SOAPy and SOAPier. So SOAPy is adding implementation and evaluation. Well, implementation just takes it to the next step and documents the actual activities that we do for the patient. So if we are actually doing a certain intervention for a patient, we would document that after the plan. And then evaluation is coming back and documenting the patient's response, not how we performed our intervention. It's how the patient responded to the intervention and, did it help? So, yes, I'm going to say the patient complains of pain, okay? That's their subjective. Their objective is I see them grimace, they're wincing when they move, they're moving really slowly, they're guarding the area that's hurting, and their blood pressure's elevated. I've got all this objective data. So my assessment is the patient's having an alteration in comfort, pain. My plan is to manage the pain using multiple techniques. I will probably, if it's time for medication, I'll probably offer them pain medication. But maybe that's not it. Maybe I need to help, change their position in the bed also, or alter the temperature in the room. Maybe they're too warm and that's aggravating the pain. But I'm going to do my interventions to include give pain medicine. So I'm going to document that I gave pain medicine. That's my implementation. That I change the temperature in the room and I help the patient change position. Then I'm going to document my evaluation. 30 minutes later, I will come back and say, to the patient, how well did that relieve your pain? I'll have them quantify it on a pain scale. And there I've got everything, my SOAP-y note. Then revision is if all of that, didn't work, or if something is no longer a problem, we need to go back and revise that original plan of care. Then that's what we do with the SOAPier. We add a revision to that plan of care. Progress notes are used a lot by physician. Progress notes are focus charting. It structures the progress note according to the focus of the note, meaning if we're doing a respiratory assessment, we're not doing a head-to-toe assessment. We're doing a respiratory assessment. So it uses keywords that describe what's happening to the patient, and it lets us know what that note is about. So it's always got to be some current client problem, concern, behavior. If the patient has a significant change in their status, or they have a significant event in the patient's therapy, all of those things deserve a note of some variety. Patient sitting quietly watching television might not be a note worth, noting unless they had been screaming in pain 30 minutes earlier. Now that would be important information because you're talking about a response. Whereas if you're just making a note that the patient's sitting quietly watching television and it really has no meaning behind it, there's no reason to chart that. It's not a significant event. So this is a type of note They call it data action response, and you'll see this sometimes with physicians, but really the data is just squeezing that subjective and objective data from the SOAP note all in one spot. The action goes back to the plan and the intervention, what you plan to do and what you've done about it, and then the response goes back to that evaluation. How did the patient respond to what we did? So even though it's called something different, it's structured just like the SOAP note, they're just giving it a different name. Now, charting by exception is something that's a little bit more difficult for people to understand. Charting by exception is a documentation system in which only the exceptions to the norms are being recorded. So you're not going to record their vital signs on there if their vital signs are normal. Okay, it's going to be assumed by the symbols that you use in the flow sheet that if you check mark where vital signs are, that the vital signs were normal for that patient. But if you write in a blood pressure of 180 over 104, well, obviously we know that is an abnormal blood pressure, and so that is being documented. The abnormals are being documented. The three components to charting by exception is, first of all, you have to have unique, specialized flow sheets which highlight specific areas and define the assessment parameters. The problem with this is the first two words in that sentence, unique and specialized. So there's not one flow sheet that works for everyone. This is a flow sheet that you've got maybe one flow sheet for your asthma patient. You've got one flow sheet for, a post-op this or a patient with COPD. You've got a flow sheet for every single diagnosis, basically. So you can imagine there is a huge learning curve to learning these documents. They're not saving you a whole lot of time if you're spending a ton of time trying to just read the flow sheets and decide if you know the normals and abnormals. But once you get that learning curve down and you know what's on that flow sheet, you can document an assessment under like 2 minutes because you know what's on the flow sheet. You're using check marks and lines and things to depict different areas so that you don't have to write everything out by hand. Usually these forms are all at the bedside, so they're very easily accessible, and the normals are pre-written. So as long as it's all normal, you are not going to be writing anything. So in this example, if you look up here let's just go to cardiovascular. It says skin, warm and pink, peripheral pulses palpable, good capillary refill. They're not being quantifiable there. I would say cap refill less than 3 seconds, but no calf tenderness, heart sounds audible, regular rhythm. If all that is true and all that is normal, if you look up here where the check marks it says findings according to printed parameters. So all I would have to do is do a check mark. Instead of a huge written out assessment for the cardiovascular area, I would just write a check mark. Now I hope that you can see that could, in the long run, save you a lot of time. But this information in these boxes is going to vary slightly for different diagnoses. So you're going to have to learn what's in each one of them. That's why I was talking about the learning curve being, so high. If you didn't assess it, because you don't assess everything every time you walk in the room, you just draw a line down through the boxes that you didn't assess. If you did have something abnormal in one of these boxes, and you came back later, because this is for date, time, and initials, if you came back later, 2 hours later, and the same abnormals were happening, you just literally write this arrow to the right, and that basically says that same set of abnormals continues. So you don't even have to rewrite all your abnormals if they are the same as they were the first time that you assessed them. So it's a huge time saver. Once you have the learning curve down and you know what's on the sheets, you can literally document an assessment lickety-split on these things. Huge time saver. Okay, traditional care plans are care plans written for each client. Now we are going to learn how to do this, and you are going to be starting that very soon in PVC if you haven't already. But there are standardized care plans where we basically say that every patient who has an alteration in pain probably has some of the same reasons for the pain. We are looking for some of the same outcomes for that pain, and some of the same interventions are going to work for that patient. However, no matter how good those standardized care plans are, guys, you must individualize that that standardized care plan. So this is where you guys get in trouble when you try to write your care plan directly out of a care plan book and don't make it fit your patient. You guys try to make your patient fit what's in the book rather than what's in the book fit your patient. Care plans have to be individualized to the patient. We don't make the patient fit something that's in the book because it's easier to write, okay? In most cases, if you use common sense and you've got some background information, you can figure out what you need to do for that patient and not just copy straight out of a care plan book. Lisa's going to talk about this in your care planning, lecture, and she'll be talking about the fact that you can't just copy things right out of that book. You've got to take those things and you've got to apply it to your patient's situation. So standardized are nice because it speeds up the process a little bit, but when you're going to write a traditional care plan where you are writing a very specific care plan for each patient, you're going to start with your PVC patient and you'll move into your clinical patients as well. And by the way, a care plan book never replaces good judgment. Care plan book may tell you to do something, but because your patient has some other alteration it's not taking into consideration, that would be a contraindication for your patient. Well, you can't write that thing down and say, well, I got it out of the book, because ultimately it comes back to you doing what's right for your patient. So here's a sample nursing care plan. We have the nursing diagnosis, which is altered comfort, pain related to surgical procedures, so they had some kind of surgical procedure. My goal or my outcome, if my problem is pain, now a lot of people want to write no pain there. I hate that, because honestly, if you just had surgery yesterday, is it a realistic goal that you will have zero pain? That's not realistic. Why should I let the patient think that that's possible? What we want their pain to be is very tolerable. They can have aches and they might feel a little uncomfortable, but we should have any real pain under control, so tolerable pain. Then you have to list measurable ways to prove that this goal was met. And we can talk about some of those ways that you can measure that, but they have to be measurable. You can't just say that patient will have less pain. Well, how do you know they have less pain? Then you're going to have your interventions. Your interventions should be lined out. First one should include your assessments. The second, third, and fourth should be things that you are doing to reduce your patient's pain. And usually the last one focuses on some kind of teaching. There's always a little bit of teaching that can go along with each one of these care plans. Then when I go back to evaluate, since my goal was tolerable pain, I'm asking, is that pain tolerable? If it is, great, goal met. If it's not, well, then we're going to have to reevaluate our interventions. We're going to have to reevaluate the entire thing and see if we need to do things differently.